Chelsea Proctor and Sean Flowers, and as you can see, their titles Self-Efficacy Regarding Acceptance and Future Directions. Please help them welcome.
Hi, so my name is Chelsea, and our study focused on self-efficacy regarding acceptance, which we abbreviated as SERA, so I'll continually refer to it as SERA at some points. So what is self-efficacy regarding acceptance? Well, basically, what it is it's just a person's belief in their ability to accept their negative experiences, emotions, and thoughts. And so this can be seen in the way a person deals with negative things that happen to them. Like, for instance, if a person experiences some negative sensation, like maybe if someone's going through a lot of anxiety, they might have difficulty accepting their negative states. And what the SERA measure does is it determines to what extent a person is able to deal with and accept these negative states. And these states could be divided into cognitive, emotional, or physiological. And so we originally wanted to look at SERA since it could potentially be beneficial in a clinical setting. And so we created a new 36-item measure regarding acceptance we divided acceptance of negative states that we divided into those three sections of cognitive, somatic, which involves physiological sensations, and affective, which involves emotions. And just to give you an idea of what some of the items were from those three, one of the cognitive items were I cannot accept sad thoughts. One of the somatic items is I can accept having some blushing or flushing. And one of the affective items are I cannot stand being afraid. And so our method involved collecting data from 590 undergraduate students using online surveys through the service SurveyMonkey. And concerning reliability, we found that the SERA measure appears to be a reliable measure based on our results, since it had an inter-item consistency of 0.87, and there was also a correlation of 0.71 to 0.76 within subscales. And to determine the SERA measure's validity, we included related measures in our survey, and some of them are named on this slide. So we used the Regulatory Emotional Self-Efficacy Scale, or REES for short, and that's just a brief measure that looks at how well people are able to keep from getting upset. And some items from it are, how well can you rejoice over your successes, and how well can you keep from getting discouraged in the face of difficulties? We also use the Difficulties in Emotional Regulation Scale, or DIRS, and that's just a measure of difficulty functioning while upset. And some items from it are, when I'm upset, I acknowledge my emotions, and I know exactly how I'm feeling. We also use the Acceptance and Action Questionnaire, or the AAQ2, and that's just a brief measure of being able to avoid difficulties from worries, negative feelings, and memories. And some items from it are, it's okay if I remember something unpleasant, and worries get in the way of my success. So this table just shows some of the correlations between our measure, the SERA measure, which you can see at the top row, and it shows the subsections of it, affective, cognitive, and somatic. And on the left column, you can see the different measures we compared it to. So you can see the ones I mentioned, the DIRS, the REES, and the AAQ. And for the correlations with those, in regards to convergent validity, we saw low to moderate correlations between our measure and those related measures that I just mentioned. And additionally, we used something called the Positive and Negative Affect Scale, or the PANAS measure, and you can see those mentioned right here. And we also used two extensions of the PANAS, which we created just for this study, the PANAS-C and PANAS-S for cognitive and somatic, to help the PANAS better fit in with the SERA subsections. And for the correlation with the PANAS, we saw that there was a somewhat lower correlation between our measure and the related measures like the REES and the DIRS, compared with the PANAS measure that measures the level of these negative thoughts and feelings. So the SERA measure was also found to be predictive of optimism and overall life satisfaction, and we included these two scales, the Life Orientation Test, or the LOT-R, which measures optimism, and some items from it are, in uncertain times, I usually expect the best, and if something can go wrong for me, it will. And we included the Satisfaction with Life Survey, or the SWLS, to measure overall life satisfaction, and some items from it are, in most ways, my life is close to my ideal, and If I could live my life over, I would change almost nothing. And you can see I pulled these rows from the table on the previous slide, and it just shows that there were also low to moderate correlations with the SIRAW measure. So to sum things up, the SIRAW measure appears to be a reliable and valid measure for assessing self-efficacy regarding acceptance, and it was also associated with lower levels of uncomfortable feelings, greater life satisfaction, and higher optimism. And future studies will look at acceptance and experiential avoidance in clinical settings. And now Sean is going to talk to you about the future directions of our studies.
Right, thank you so much, Chelsea. I'm gonna come over next. Okay, so in terms of future directions, when we're looking at a measure like acceptance, it's helpful to look at related measures to be able to, tackle aspects of it that we might not have covered the first time. And so a related measure to acceptance is experiential avoidance, or EA for short. It is the opposite of acceptance, and involves the avoidance of painful emotions and experiences, and we chose this as our dependent variable, as measured by the brief experiential avoidance questionnaire. So it leaves us, since we have the dependent measure, what about the independent variable? Well, we want to choose something that was related to EA, and I came into Dr. Sturge's lab, with an interest in adult attachment theory. And so I thought, okay, maybe attachment theory could be related to that. And adult attachment theory is basically the idea that all of us, no matter how old or young we are, no matter what experiences we've had, we have a genetically wired need to feel secure in our connection with other people in order to thrive. But even though we have that need, all of us, given that we have different experiences, will feel, different level of comfort with that need. And so that gets expressed in one of three attachment styles. Secure attachment refers to people who are very comfortable with, depending on others, allowing others to depend on them, and they're not overly afraid of being rejected or abandoned. Anxious attachment refers to people who want a lot of closeness, who crave it, in fact, but they're not sure where they stand in relation to other people. They need reassurance quite often, and they're afraid that other people might reject them or abandon them. Avoidant attachment refers to people who have the need for closeness, but they're not very comfortable with it. They tend to, push people away a little bit, not very comfortable when people get too close. And so they tend not to be very in touch with their feelings and that sort of thing. Now, I want to ask you guys, by show of hands, anyone take a volunteer, which one of these attachment styles sounds most like experiential avoidance, the avoidance of painful emotions and experience, by show of hands? Yeah?
Avoided.
Yeah, that's what we thought exactly. So we thought avoidant attachment, so okay, maybe among the attachment styles, we could look at avoidant attachment's relationship to experiential avoidance. But then we thought, okay, we also know people who have an anxious attachment style, and sometimes if they're going through a painful breakup or something like that, they might engage in experiential avoidance, avoidance of painful emotions and experiences as well. And so we thought, okay, now we have two things we're looking at. How do we actually compress it into one? Well, when we look at the attachment literature, we find that secure attachment consists of low level of anxiety and low level of avoidance. And so if these are associated with higher experiential avoidance, then perhaps the opposite of both of these would be related to low experiential avoidance, hence why we chose secure attachment as our independent variable. Now, we're looking at the clinical population now, therapists and our clients in therapy, and we wanted to ask, okay, with their attachment style, you can look how they feel in relation to people in general, in terms of connectedness, or you can look at relationship specifics such as romantic partner or even to the therapist. And we decided upon, specifically client attachment to therapist as measured by the client attachment to therapist scale, secure subscale. And that leads us to our hypothesis. We predict that as client secure attachment to therapist increases, experiential avoidance will decrease. And this just means that as the client feels more comfortable depending, trusting in the therapist, he or she will be more in touch with, will communicate more about painful emotions and experiences, as in indicating possibly acceptance. To test this hypothesis, we propose to do a 5-wave panel study, and you can consider it like a repeated measure study. And basically you have 5 waves, they correspond to 5 counseling sessions. And so during the first session, we want to give the informed consent to the client and the therapist, and if they both consent, have the therapist give the clients both measures, independent and dependent measures. There's 29 questions total on both of them. 15 questions for the independent variable, secure attachment, and 14 questions for experiential avoidance. And we're going to use a 6-point Likert scale on both, ranging from strongly disagree to strongly agree. In terms of the analysis, we want to look during the first session. We want to look at multiple clients, instead of just one. We'll look at multiple ones, and we want to do a Pearson R. Since our hypothesis is that as secure attachment increases, experiential avoidance will decrease. We expect a negative correlation, and we expect a negative moderate level correlation for that. And we think it's not only going to apply during the first session, but across sessions. So you can think of it as repeated measures. And if that is the case, then it would seem to support our hypothesis. And if our hypothesis is supported, it can lead us to two conclusions. First, that we found a new measure of acceptance in the client attachment to therapist scale, secure subscale, and that would actually predict acceptance in therapy. But second, instead of looking at acceptance from an individual personality perspective, what traits the individual has within him or herself that contribute to acceptance, we want to look at the relational context or the dyadic perspective, the dyadic context in which that client is embedded as a predictor of acceptance in therapy. Now, as far as we can tell, when we did the literature review, and we did that for a couple of months, we did not find any study that looks at this directly. We might have seen how attachments, predicts therapeutic outcomes, or how attachment might, assessed across therapy, might predict lessening of symptom severity. We've even seen studies that look at how attachment might predict quality and strength of working alliance, but we've not found any study that looks in particular at how client secure attachment to therapist can predict acceptance in therapy. And if that is the case, we're glad to be doing that here at Cal Poly Pomona. Thank you very much.
Okay, any questions? Any questions?
Yeah.
So did your, the scale that you talked about at the beginning that you developed, did it include any sort of like reverse coding or anything to deal with social desirability?
I believe it included some reverse coding.
Okay, was social desirability something that you were concerned about at all? People, honestly answering these questions?
Not specifically. We were more looking at acceptance.
Now for your future study, you're thinking about using clients, right?
Yes, clients in therapy.
And so are you targeting a certain number of sessions? So are you going to?
Yes.
So you'll be testing at various intervals?
Yeah, we're actually looking to do 5 sessions and for every single session.
Okay, so every single session.
Absolutely.
Okay. And you mentioned the informed consent. What is the informed consent going to inform them of? Is it going to tell them that they are participating in a research study, basically like we do with all of our informed consents?
Yeah, and we might not let them know of the hypothesis directly and everything. Okay. We're going to kind of nuance that just in case it might influence, the results. But we want to be able to make sure that, the client doesn't feel like he or she's going to be watched by the therapist with regard to this, and that the therapist doesn't feel like he or she's being evaluated.
Any other questions from the audience? So was there anything in the first part that you were most surprised by? Was there anything that said, gee, I didn't expect that? What were you thinking?
Not specifically, because we kind of expected those results.
Okay, very good. All right, thank you so much.
Thank you.